So welcome back to I'm Still Here. I'm Heather Jose. In 1998, I was diagnosed with stage 4 breast cancer, and I was 26 at the time, and it changed everything for us. I'm excited to introduce today that I have somebody that I think started at U of M about the same time that I came to U of M. So this is Cara. Cara, would you like to introduce yourself and tell everybody what you do?
Sure. Thank you so much, Heather. This is I'm so glad that you're doing this podcast, and I'm so honored that you asked me to be a part of it. So thank you very much for having me. So my name is Kara Milliron. I'm a adjunct counselor here at the University of Michigan Rogel Cancer Center. And as Heather said, I've been here for a long time, 24 years. I won't say how much of my life that has been, but pretty close to that. But the reason I've been here is that I love my job. I love the U of M, and I love the people that I work with. So when that all falls into place, it's just the best. So that's why I've been here. So I've been a adjunct counselor, as I said, for about 24 years, and I work in the breast and ovarian cancer risk evaluation program. So my job here is to work with our attending physicians, Dr. Sophia Mariver, who's our medical director, and Dr. Erin Cobain, who is another one of our attending physicians. And we see a variety of patients. We see patients who have a long-standing diagnosis of breast cancer, who are, several years out from breast cancer. We see patients who have newly diagnosed breast cancer. We see patients that have ovarian cancer. We see patients that have a family history of breast and/or ovarian cancer. So we see a number of patients a year. We have grown significantly. When I was here in 1998, I have to laugh that we saw 60 patients, I think that year in 1998, and we saw more than 60 patients last month. So it's been an amazing ride to see, and we have grown in JET counselors as well. We have 2.75 JET counselors who work in our clinic, but Lauren, who is that technically 0.75, I think she puts in 1.5. So we're very, very lucky to have the really great team that we have.
So before we get into all of it, 24 years ago, how did you find out about being a genetic counselor? What led you down that road? Because I mean, there's been a lot of change in that time, right? I would think.
Yeah, I was thinking about this because it's a student move-in coming up in a couple of weeks here at University of Michigan, and some of the students are already back, and you always get a little bit, I don't know, you always kind of get a little bit nostalgic for those days. And I went to Grand Valley. I was set on being a physical therapist, and my freshman year, my mom unfortunately passed away from lung cancer. And second semester of my freshman year, I started human anatomy, and unbeknownst to me, Grand Valley at that time, and they still may at this time, I don't know, but they used cadavers. I walked in, I walked out, and it was just not a good fit. And I was very, very lucky to have an advisor who said to me, I don't even think PT is a good fit for you. You need to look into this. And I was blessed because Grand Valley really worked with me to sort of create my own undergraduate major so that I could, be successful in graduate school. But the first step was getting a volunteer internship which was then Butterworth Genetics Department. Butterworth and Blodgett have, of course, merged into Spectrum, but at that time it was Butterworth. And there's a wonderful genetic counselor there by the name of Cara Lewis, who just was absolutely a wonderful mentor, and to this day is a beloved friend of mine. But I got to see genetic counseling firsthand. Now that was in a prenatal setting, and I thought, when I went to grad school that I would end up, being a prenatal genetic counselor. And 24 years later, I'm in the cancer clinic, and I haven't left. And this has just been an exceptionally good fit for me. But
so were you just like were you just like looking at other kind of careers within healthcare to get to genetics, or do you not really know how that all came
No,
about?
I fell in love with genetic counseling. I
Okay.
put the eggs all in one basket,
Okay.
although I didn't get into graduate school the first time I applied. And so that was very upsetting.
Sure.
It was difficult, but in retrospect, it was the best thing
Yeah.
for me because I got another year to beef up my application. I had another year of volunteering, and so the second year I applied,
Okay.
I was
Yeah.
accepted. And so off to the University of Pittsburgh, I went, and it was still kind of interesting, when I told my dad that I wanted to be a genetic counselor, he was trying so hard because, he, all of a sudden had to be both parents and
Yes.
trying to be supportive. And I could still see the fear in his eyes, though. I'm going to be supporting her for the rest of my life.
Oh, yeah.
Thankfully that hasn't happened. Um, you know, I have a lot of biology skills, lab
Mhm.
skills, and you know, that just never really crossed my mind because I don't enjoy the lab work. I enjoy
Yeah.
the people part.
Yeah.
One of my really very, very close friends works in law enforcement in their DNA lab, and she loves the lab work
Got it.
and loves, you know, um, interacting with, the liaising with all of the,
Mhm.
police departments within the state. And that is something that just, I, I terrifies me. I wouldn't want to do
Yeah.
that. She's like, well, what you do terrifies me. So it's a
Yeah.
good thing that we both found our own niche, with
Yeah.
so
That's interesting. I just have to tell you, I went to Western to be an occupational therapist, right? And so we also had a cadaver lab. And my brother was at Western at the same time, and he was kind of pre-med. So he was doing his undergrad at Western, and he was so um, not angry, but he was so jealous that I got access to the cadaver lab. And it was only the OTs and I think the PA program at the time that did. So everybody has their own views about
right,
cadaver
right,
lab.
exactly. I think for me it was too soon after my mom's
Oh, for
passing. I think
sure.
if
Oh,
there
yeah.
had been maybe some distance, things would have been a little bit different. But that was what happened at the time, and
Yeah.
that was a big change for me because both of my sisters work in healthcare. I'm the youngest of three, and
Okay.
my parents were both teachers, and they
Yeah.
said, don't go into teaching. And I find it highly ironic that the three of us, even though we're in healthcare, uh, do have teaching as
What
part
you
of our
do.
career.
Yeah.
So
Just in your
yeah,
no, I can completely understand that, that played a role. But I think a lot of, students kind of look at healthcare and go, oh, I'll be a PT. That's a pretty common thing that I hear, even for high schoolers now. So,
yeah,
so to be able to kind of take a
yeah,
bad experience and turn it into something to actually really find what you're passionate about is awesome. So,
yeah, yeah. It was, as my dad always said, it's adversity. Adversity doesn't have to be bad.
yeah,
I learned to, pick myself up and
yeah,
brush myself off. And
yeah, yeah.
sorry.
Oh, I know.
um, um, you know, I never realized how much cancer was going to be a part of my life, because I
Yeah,
lost my parents to cancer. And so um, it's uh, it's a pleasure and a joy to work with patients and just, be a part of their journey just because, it's important to be an ally and to be there,
sure,
as a support
sure.
person. So
Yeah.
yeah.
So if I can take you back to like when we met initially, can you kind of talk about the kind of testing that we did, like for me,
Sure.
or
Yeah,
initially, we've done it
absolutely.
twice, right? We've done testing twice, and maybe talk a little bit about what that was and
Sure. So
yeah,
let me talk a little bit about the history of, cancer genetic testing
sure,
and the evolutions, that we've
yeah,
had. So two genes that are really, really important, BRCA1 and BRCA2.
mhm,
Going back to 1994, there was a major development in the identification of a gene called BRCA1, or breast cancer gene 1.
Yeah.
And then quickly following on the heels of that, there was the cloning of BRCA2 in 1995. And these two genes really were a breakthrough because, you know, previously with regards to genetics, yeah, it was interesting, but how does it apply to
Right.
healthcare and everyday life?
Right.
Really, you know, really wasn't something that everybody thought about.
Sure.
And in 1996, the first clinical testing for BRCA1 and BRCA2 became available. And around that time, the group that cloned BRCA1 and BRCA2 out at the University of Utah, they spun off to form a company called Myriad Genetic Laboratories.
Okay.
And in 1998, Myriad Genetic Laboratories started enforcing their patent. So in 1998, we had the capability of testing BRCA1 and BRCA2. And then we also had some other genes for colon cancer, Lynch syndrome, which is a genetic condition that's associated with colon polyps called adenomas, an increased risk for uterine cancer, an increased risk for colorectal cancer, an increased risk for ovarian cancer. Those were also genes that we were able to test for. And then there was also a gene called TP53, which causes Li-Fraumeni syndrome, which is associated with an increased risk for sarcomas, brain tumors, breast cancer, leukemias, lymphomas, lung cancer, and adrenal cortical carcinoma. So those are really the genes that we could test for. And we slowly, I think, got BRCA1 and BRCA2 folded into cancer care. And the real driver of that was breast surgeons, because we know that women who carry a BRCA1 or a BRCA2 gene mutation have an increased risk for developing a second primary breast cancer.
Okay.
And so breast surgeons said, well, if we can, you know, identify these patients when they're newly diagnosed and they decide, you know, that they want to pursue bilateral mastectomies as their definitive cancer surgery,
Yes.
that is very important. And so it was really interesting because when I first started in 1998, I was kind of an afterthought. You know, it's like, let's get the patient through her surgery, her chemotherapy, radiation, her hormonal therapy, and then, yeah, she can see genetics down the way.
Okay.
And what started to happen is that we were starting to see patients more and more when they were initially diagnosed. And as you know, that it's just traumatizing, that initial diagnosis. And so, you know, after, you know, seeing a patient after they've had time to adapt to that diagnosis is very different than coming in from, and when someone has that, you know, new diagnosis.
Right.
And so our counseling changed a lot and our approach to patients changed a lot. And we pretty much started, you know, seeing patients earlier and earlier in their breast cancer diagnoses. And then, of course, we had what we call cascade testing. When we identify someone that has an inherited susceptibility to cancer, their other family members are at risk. And so, you know, that's where we see even more of a benefit from the genetic testing, is because if we can identify those that are at high risk and those that aren't at high risk, we can intervene and hopefully find a cancer earlier where it's more treatable, or, you know, if they want to pursue risk reducing surgeries, we can drastically reduce the risk of developing cancer. In 2013, the patent for BRCA1 and BRCA2 was overturned by the Supreme Court. And serendipitously at that time, we had this new technology called next-gen sequencing, where we could test multiple genes at once. So within 20 minutes of the Supreme Court's decision, our jobs just changed 180 degrees, and we now test people for multiple genes. And what's interesting is that we're finding that there's a lot of breast cancer in high-risk families that's not linked to BRCA1 and BRCA2. And so a lot of times people say, well, I've already had testing, and that may be true, and they may be negative. And in that case, you know, it may be something that they want to go back and say, you know, look, is there enough information here that I should consider being retested for multiple genes instead of just BRCA1 and BRCA2.
Okay. So that's what we did.
Yeah,
Probably along that time, I would guess. I don't remember when it was.
yeah. I think it was around 2017,
Okay.
2018.
Okay.
Yeah.
So you know, it's interesting when you're talking about the timeline of things. My journey was a little bit different than a lot of people's in that I started chemo first, right? And then went on to have surgery. And I actually talk to women about this stuff all the time because they're always like, you know, when you have a cancer, everybody's initial thing is get it out, right?
Right.
But by starting the cancer or chemo first, one, for me, it was so empowering because we could see the tumor really shrinking. But
Right.
it also probably allowed us the time to do some of that genetic testing. I don't remember when we did it initially, but I would guess it probably was before I did surgery, which would have been like I was diagnosed in December and I did surgery in July.
Yeah.
You know, but it just would be, you would have the opportunity to have a lot more information
Yeah.
about that. And I know that now people aren't even doing double mastectomies. I understand that too, but it's just interesting.
Yeah. One of the things that you just sort of had a nice segue into is a lot of times, patients with what we call triple negative breast cancer, they are now getting chemotherapy up front because that has been shown to increase survival. And so now in those patients, we do typically have a little bit more time, with regards to the chemotherapy, get that started, give them a little bit more time to, adjust to the situation and then do the testing.
Right.
The testing has changed our approach to treatment as well, because in patients that have a BRCA1, a BRCA2, or a PALB2 gene mutation, after they finish their surgery, radiation, chemotherapy, they qualify for a PARP inhibitor, and they take that for about a year after they finish their initial treatment.
Okay.
And so it has changed a lot with regards to our approaches and with regards to surgery, treatment, across the board.
Yeah. There's just so many things. I remember like being concerned, of course, not for me at that point, but for my daughter, and no, just wondering what would come next for that. But I think it's always
Yeah.
an interesting thing too, to know, like, how much do you want to know and how much,
Right. Exactly. And I think that that's one of the things that is really, really important to explore,
Mhm.
because there's so much out there that if you don't, it seems in the general population that if you don't get every single piece of medical information, you're considered a bad patient. And that is not right. And
I'm
not
like the opposite of that, right?
I think that everybody has a limit where they're saturated. And
Yeah.
I believe that it's very important to be respectful of someone's boundaries and their decision-making process. And sometimes people do not want to know this information, and that's absolutely fine. Just because they don't want to know this information at that time point doesn't mean they may change their mind in the future. But it is a lot of information to take in. And it does have a very significant consequence. And so you have to be in an emotional place that you feel comfortable getting this information. One of the things that has been a little bit difficult for me is being in this job as long as I have, I'm starting to see the second generation test positive. And that's been a little bit hard because I'm split a little bit. Like, who do I, like trying to make sure that I am supporting my patient in front of me, but I also have this established relationship with the parent as well.
Yeah.
And so it becomes, who is actually the patient,
No.
and of course it's the child, but it also, I think we have to also understand that there's a lot of emotion coming from the parent as well.
Sure.
But it's so important to remember that no one has a perfect genome. We all
Right.
carry about 5 or 6 gene mutations that can contribute to a genetic condition.
Okay.
And most times we're blissfully unaware until we have a child with someone who happens to have a mutation in the same gene, and we have a child with a serious genetic condition. So there's no perfect genome, and I'm not a parent, but I have, a niece, nephews, great nephews, a great niece, and I don't want them to ever see any adversity. And
Right.
I also want them to make sure that they put me in the good nursing home, but I don't want them to see any adversity. And I can appreciate that, when
Yeah.
parents are grappling with how to discuss this with their child. And I think in some ways for parents, it's the fear of a loss of innocence for that child.
Yes. Yes.
But what I think it's important to note is that when a parent has a cancer diagnosis, there's already a loss of innocence and that child
Yeah.
is already dealing with it. And so I think children of parents in this situation are much more resilient than we give them credit for.
Yeah. I would agree with that.
Yeah.
Yeah. And I think, I mean, we're all individuals. I just even look at how Sydney handles things compared to me. I think knowledge for her is more powerful, so.
Yeah.
I have a question also though about that. It just in that, is there concern or is there protection, I guess would be the better question, of from like a pre-existing condition from an insurance standpoint? If that's, I always worry about that kind of thing, I mean, of course, I've lived through the whole, Obamacare and all that kind of stuff, and all of that talk about pre-existing conditions, which for me is just a huge deal. But then when you're potentially looking at that from the next generation, can you speak on that a little bit?
Absolutely. So the good news is that we have very strong state and federal laws that protect individuals from this information being used in a discriminatory manner.
Okay.
I have no evidence of genetic discrimination in the 24 years that I have been a genetic counselor in this counseling space.
Awesome.
The first law was passed in 1996. That was part of HIPAA, the Health Information
Yeah.
Protection and Portability Act. And HIPAA covered individuals who were in group health plans. So essentially, individuals who get their insurance through their employer.
Mm-hmm.
And it specifically states that the information cannot be used in a discriminatory manner. It
Okay.
can't be used to set premiums. It can't set coverage levels. And most importantly, it can't dictate treatment.
Okay.
What we noticed is that we were exceedingly naive about how many people buy their own health insurance. And so that's why in 2008, GINA, the Genetic Information Non-Discrimination Act, was passed.
Okay.
And GINA essentially plugged the holes of HIPAA. So anybody that has group health insurance or buys their own health insurance, that information cannot be used against them in a discriminatory manner. For federal employees, there's a federal act that states that it cannot be used in a discriminatory manner. These laws are not part of the ACA, and so I just want to make it clear that these are not part of the ACA that is constantly being talked about, and people have significant concerns about the ACA and the ability to get insurance. And I completely understand. You have to have health insurance. It's not negotiable. You just have to have it. What isn't covered by the state and federal laws is life and disability insurance. And I don't foresee those ever being part of federal laws. Now, there are some states that have put in place restrictions on life insurance and disability insurance companies with regards to genetic testing information, but it's only a handful of states.
Okay. Is Michigan one of them?
Michigan is not one of them. But one of the things that is really important to know is that they're not necessarily asking about genetic testing information. And so it's really important to make sure that you take a look at the application and what they're specifically asking for. If they don't ask, you're not obligated to tell, but if they do ask, you have to tell them, otherwise it's fraud.
Okay.
However, with regards to life and disability insurance, what we typically talk to patients about is that if you're interested in getting life insurance or making any changes to those insurances, go ahead and do that prior to undergoing testing, because policies that you have in place are completely, totally safe. It would just be if you wanted to get or add to that life insurance policy. But the last few patients that have gotten life insurance prior to undergoing genetic testing have reached out and said, I know we talked about this, but there were no questions on the application about genetic testing. So I think that that's a really important point to share, because a lot of times that is a barrier, that individuals don't pursue genetic testing because they're concerned about that. Although sometimes I think that people don't necessarily want to know, so they use that as an excuse to not pursue the genetic testing, because they don't really want to tell their loved ones that they don't want to do it, and that is a better societal reason than I just don't want to do it. And but again, this is a very personal choice, and
it is. I mean, from my standpoint, we have the whole cancer thing going on, but my dad died of a dementia that is genetic, right? Like there's a genetic component to it. And I have two brothers, and I don't want to know, you know what I mean? And we're kind of getting to, again, the conversations come up again a little bit. It's, I guess I feel like in that situation, there's nothing I could really do about it. There's not any sort of treatment. So I don't know. I feel like it would just send me sort of into a tailspin of how much time do I have, or is this really going to happen? Right.
Exactly. And, that is a very valid point. And that's a very valid reason to not pursue the testing, and shows a significant amount of self-awareness. And I think that that is something that's really, really important to explore. So many times people say, oh, it's just a blood test, or it's just a saliva sample. Okay, technically, yes, but there is a huge amount of social issues that go along with that information.
Right. Well, and having been the one who, like, I've gotten the phone call that has changed my life, like you kind of go, wait a second, some days are normal and sometimes it changes this quickly. And those kind of things do have the ability to do that, right?
Yeah, it's still somewhat difficult to call people with those positive test results. It's not somewhat difficult, it is still difficult.
Yeah.
But that's why I make sure when I talk to the patient, and we make a plan, because if someone doesn't want a cold call, if they want to have a specific date for their phone call, or if they want to have a video visit, because now we have video visit, or if they want an in-person visit to have those test results, revealed, that is their choice, and I want to make that as comfortable as possible for them. It's very interesting. The young people typically just want a phone call. Other older people want a support person there. So it's kind of interesting to see the differences between the generations. And the younger generations, well, can't you just text me or email me? So like, no, you have to have a phone conversation about this information. So, but I think that, the most important thing to keep in mind is that this is information that can be used for good. We have a lot of interventions that we can offer. And what has happened in generations past, if we follow people appropriately, we can make sure that what has happened in the family story before doesn't happen in future generations. And I think that that's really the important point to drive home, is that this information is a gift.
Absolutely.
And one of the things that is also lost, I believe, when patients and families are talking about cancer, is there may be an excess of cancer in the family, and we haven't been able to determine genetically what's contributing to the excess of cancer. And there's the opportunity of DNA banking, and that is something that is really underutilized in the US. It's very simple to set aside a sample of DNA from the matriarch or the patriarch of the family. And if any new additional genetic testing options become available, we have a DNA source to test. And, that is something that
Wow.
I feel personally should be part of everybody's estate planning.
Absolutely.
So,
Wow.
yeah. So, we didn't have the benefit of that knowledge. My mom was diagnosed with her lung cancer at 48 and passed at 53. And, that's exceedingly young for lung cancer.
Absolutely.
Probably was, unfortunate, random chance.
Yeah.
But I look back and I was like, wow, I really wish that we could have, set aside a sample of her DNA so that, we could, evaluate if there was anything that she was born with that's contributing to, her lung cancer.
Absolutely.
I was luckily able, when my dad was diagnosed with his pancreas cancer, it was an extremely short time period that, he was diagnosed and unfortunately passed away within a week. But I was able, to get a sample of his saliva, and, we were able to do a very broad genetic test prior to his passing. So we were lucky to have that information. But I think that there's a lot that we can do
Mhm.
to assist our families in this,
Wow.
clinical space.
Absolutely. That's amazing. It is kind of like being able to, I don't know, share well, you know, even after you're gone or whatever. That's amazing to think about.
Yeah,
So,
yeah,
Kara, can you tell me? I mean, I know how I came to you because I had cancer, right? But who else comes to you? Who says, "Hey, this is what's going
yeah,
on," or
yeah. We wear a lot of different hats, which is great. As you know, Dr. Milleyer, my boss, is just absolutely fantastic and just is an amazing woman, and has so
Mhm.
many hats that she wears, but
Yes.
with
Yes.
regards to her job. We also have a new wonderful physician who is also a medical oncologist, Dr. Erin Cobain. She started working with us in 2017. Um, she covered Dr. Meyer's sabbatical, and then we were lucky enough 2 years ago that she started back with us, but this time full time.
Mhm.
We see everybody that's interested in breast cancer and ovarian cancer risk assessment. So this is a clinic that is open to everybody who has concerns.
So you don't
Uh,
have to have been diagnosed,
no,
right?
no,
It could be
we
that a family member was or something like that.
exactly. Yep. So I would say about 50% of our patients have a diagnosis of breast or ovarian cancer,
Mhm.
along with a family history. They may or may have a family history. And
Okay.
about 50% of our patients have a family history of breast and ovarian cancer.
Okay.
We usually try to start genetic testing with a cancer survivor
Mhm.
because our best chance of finding a gene change is in a breast or ovarian
Yeah,
cancer
and it's like that
survivor.
banking, right? If you have,
Right,
yeah.
right.
Okay.
So genetics is very interesting. Some genetic conditions, that people may have heard of: Duchenne muscular dystrophy, hemophilia, sickle cell anemia, cystic fibrosis. There's only one or two ways genetically that those genetic conditions can occur. And cancer is so different. Cancer is very complex genetically. And there are genes that we know about, and we sure know that there are other genes out there that
Right.
just haven't been discovered.
Right.
So what we try to do is, in a breast or ovarian cancer patient, is we try to test and see if any of the genes that we know about right now are contributing to that cancer diagnosis.
Okay.
And sometimes it can be helpful for the patient for treatment. For example, if someone has a BRCA1, a BRCA2, or a PALB2 gene mutation, they may qualify for a PARP inhibitor. Or if they have a Lynch syndrome gene mutation like MLH1, MSH2, MSH6, PMS2, or EpCAM, they may qualify if they have a cancer diagnosis for immunotherapy. So we truly try to see if any of those genes that we know about are contributing to our patient's story. And then if we do find a gene mutation in that individual, depending on how the family members are related to them, there may be other relatives that are at risk for that particular mutation. And that helps us identify family members that may or may not be at increased risk. Because if there is a mutation in the family that's contributing to the excess of cancers that we see, and that individual tests negative, their risk goes back to that of the general population.
Got it.
Now, for people who don't have a cancer diagnosis, but who have a family history, we try to initially test someone who has a cancer diagnosis, but sometimes that's not possible. The individual may have passed away, or the individual doesn't want that information, which of course is their right as a patient. And we can test people that don't have a cancer diagnosis. It's just that if the test results come back negative, don't get me wrong, I'm very, very happy, but I do have to be a little bit cautious in how I interpret those test results, because I haven't been able to compare their results with a relative that has had a cancer diagnosis.
That makes a lot of sense.
But in those situations, if the test results come back negative, we fall back to our risk assessment models for breast and ovarian cancer and formulate a plan for further follow-up. Sometimes that can be increased screening. For example, in breast cancer screening, if someone's deemed at high risk, we do mammograms and breast MRIs every year and a clinical breast exam every 6 months. For ovarian cancer, we still do not have a screening tool for ovarian cancer that works. And that is the only thing that has not changed about my job, is that we still are struggling to find ovarian cancer at early, more treatable stages. So unfortunately, if a woman is found to be at increased risk for ovarian cancer, we still talk about having the ovaries and the fallopian tubes removed, because that has been found to reduce the risk of developing those cancers by at least 90 to 95%. So it's a very significant risk reduction.
Which is, it's one thing if you're my age, right? And, I just turned 50, to say, sure, take them out. But it's a whole nother thing if you're 22, right?
Right, exactly. So one of the things that we're blessed to have is the National Comprehensive Cancer Network, or NCCN. That's a network of NCI designated cancer centers, and they set up guidelines for treatment for cancers, but also they set up guidelines for who is appropriate to offer genetic testing to, and what are the guidelines if someone tests positive, what are the recommendations moving forward. And if someone has a BRCA1 or a BRCA2 gene mutation and are at increased risk for ovarian cancer, it's usually recommended for BRCA1 mutation carriers that they think about having the ovaries and the fallopian tubes removed between 35 and 40. And for BRCA2 mutation carriers, it's recommended between 40 and 45. However, women are, delaying childbirth. And so that does have some significant consequences. So sometimes women look into freezing eggs. Sometimes they look into pre-implantation genetic diagnosis, which involves in vitro fertilization, but it screens the eggs or the embryos for the BRCA1 or BRCA2 gene mutation, or whatever, gene mutation. Or prior to implantation. So, there's a lot of reproductive endocrinology options out there for patients. And so it's important to let them know that there are opportunities there. There's also other opportunities like adoption, donor egg, donor sperm, so just because you carry a gene mutation doesn't mean that you can't complete your family if that's something that you want to do.
Well, it's interesting that you mentioned adoption, though, because I think about my son who is adopted, who we just don't have any genetic information about. So again, I think about like genetic testing, for me, it's just kind of out of curiosity more than anything. But I know that's a big concern when you're adopted and have no ability to kind of draw from any family history, right?
Right. There are several reputable genetic testing companies that do offer genetic testing for inherited susceptibility to cancer and inherited susceptibility to cardiovascular disease for individuals who are in that situation. Sometimes it's covered by insurance, sometimes it's not. Although the self-pay options, the prices have decreased very significantly, around $350 to $400, which I realize is, well, it used to be a car payment. Now it's a half of a car payment, right? It's still something, it's still not, your $20 copay, but that is something that I think a lot of individuals who have very limited family history have been availing themselves to try and get more information. And because, open adoptions in the US haven't really been a thing since, I think, just like the 1980s,
Yeah.
really. So there's
Yeah.
a lot of individuals who, have closed adoptions in the US, or like Ty have, an international adoption, and, the information is sparse or non-existent.
Non-existent. Yeah.
Yeah, yeah.
Yeah. So if you were, that would, I don't know, that's just interesting. I hadn't really thought about it before then. Of course, we've done some, like we did the ancestry or whatever, just again, hoping to maybe make a connection somehow,
Yeah, yeah.
but
A lot of people who are adopted do pursue that.
mhm,
And I think that it's a very powerful tool,
sure,
but it also brings up privacy concerns.
absolutely.
You know, a lot of my patients are saying, "What happens with my genetic information?" And I said, "Oh, no, it's not going to be uploaded, to any databases. There will
Yeah.
be no familial searches." you know, um,
Yeah.
and they're always so cute. They're always like, "Well, I may have watched a little too much 48 Hours or Dateline," and I watch those too.
Yeah.
And I completely understand your concern.
Mhm,
But the testing that we do does not get uploaded to any of those
yeah.
databases.
Well, I'm
So,
about to do some sort of saliva something for Dr. Mariver here. I have
oh,
the kit on my
oh,
desk.
wonderful.
So I don't know what that's going to exactly, but whatever. I now that I've learned more about it, I'm more willing to do some of those things. I remember there was a point I think in the operating room or whatever, doing a surgery at U of M, and somebody was like, "Hey, can you?" And I was like, "No," like they were asking for consent to have something, and I don't know. So
And I can imagine Dr. Pass was like, "There, let's go, let's go, let's get it."
no, this was way after that. It was a
Oh,
totally different
oh,
surgery.
okay.
And I don't know, I can't remember, I've had a few surgeries.
Too.
So they all run together. But yeah.
Yeah.
Well, Kara, is there anything else you would like to share with my audience before we get going?
Yeah, absolutely. One of the things that I do want to just share is that, there is a myth that insurance companies don't cover genetic testing. If you meet guidelines, the insurance companies do cover the cost of the genetic testing. The out-of-pocket costs have been significantly reduced now that the patent has been overturned. Most private out-of-pocket labs, it's around 250, 350. So it's, something that has become um, much more available
Yeah.
to our cancer population and those that have a family history of cancer. And so I really want to stress that, because I think that there's that myth out there, and people really are not being seen, and that's a barrier because they think that. The
Yeah.
other thing is what we've already talked about is, the concerns about discrimination. And I
Yes.
can be very, very reassuring. We have seen none of that. And I know that that's also a barrier for people to come and see us. The
Mhm.
other thing is that just by coming to an appointment doesn't obligate you to do anything.
Yeah.
Genetic counseling is non-directive. Our job is to give you information so that you can make the right choice for yourself. And
Yeah.
sometimes people say, "You know what, I don't want to do this." And that's absolutely okay.
Yeah.
Sometimes they say, "You know what, I'm going to come back to this. Like, I have a lot on my plate
Yeah.
right now. I'm going to come back to this." And sometimes people say, "I want to go do this right now." And I'm like, "Well, I can't draw your blood or your saliva through the video visit, but
Right.
I will definitely do
Right.
everything I can to move this along." So it's
As,
just
I was just going to say, as far as the DNA banking goes, what's the process for that?
so usually what happens is that there are several DNA banking facilities across the country. One of the things that I would encourage people to do is just make sure that the company has been in business for a while, and because you want to make sure that 20 years from now, if your relative needs to
Yeah.
that sample, it'll be available.
Mhm.
But there are several companies across the country. What they usually do is send a saliva kit for the relative or the individual to collect their saliva, and then they store it, not the saliva itself, but they extract the DNA from the saliva, and then they store it. It's almost like a safe deposit box for your DNA, and then you designate who you want to have access to that bank DNA if you're no longer here, and that relative can then pursue genetic testing on that sample. Now, there won't be insurance coverage because the individual has passed away, and so their insurance is no longer active. But again, the out-of-pocket costs have significantly gone down, and so it's much more affordable than it used to be.
Wow, that's very, very interesting. Definitely worth thinking about a little bit more. So,
Yeah.
Well, thank you so much.
Oh, thank you. This has
for
been so
being part of
enjoyable.
this.
I was a little nervous.
Yeah.
I was like, it's Heather. It'll be
Have
okay.
you heard our podcast? We just banter. So there's nothing that you
Yeah.
can. So
Yeah, I am. And if there's any additional questions or concerns that come up, I'm happy to answer any questions, or, if there's ever like you want to have a podcast Q&A, I'm happy to come back and talk. So
that would be great. So yeah, absolutely. People can put comments or questions. And is there maybe a website or something that I could link?
yes, so the U of M's website is the www.rogelcancercenter.org.
Okay.
And then there's also www.nsgc.org, and that's a nationwide and also international database for genetic counselors in the US, Canada, and England and Australia. And if you're not local but are interested in talking to a genetic counselor, you can find a genetic counselor in your area. With the pandemic, a lot of genetic counselors are doing telemedicine. For example, we've been telemedicine since the first cases showed up in Michigan, and we're going to continue probably, for the next 6 months at least, probably longer. So there's a lot more availability for people, especially people in rural areas. That's been one of the things that I think has actually been a good thing about the pandemic, is that we've been able to increase access. And coming from such a small town in northern lower Michigan, that is something that I've always been passionate about. And so if someone is in the state of Michigan and wants to be seen, they can be seen by video visit, and they don't have to leave their home. A lot of people, it's a trek to the University of Michigan, and so we can make it as easy as possible for them.
Yeah, that's awesome. So I gotta believe the field is growing.
Yeah.
So
Yeah,
maybe a good time to be
5,000. Yeah, there's 5,000 genetic counselors now nationwide. So slowly but surely, and we have a training program here at the University of Michigan. We typically take about 6 or 8 students a year. We have a dual degree program with genetic counseling and public health. So some years it's a little bit a larger class, some years it's a little smaller class. I graduated from the University of Pittsburgh, and I had 12 individuals in my class, which, as I'm sure in your graduate program, you're bonded to your classmates, were bonded as well.
Yeah, my cohort was, I think, 40, but yeah, we all knew each other. So
yeah. So we're trying to increase the number of genetic counselors, increase the number of training programs and the students that are accepted. And so, our goal is to increase that number, and also, increase access in, other ways as well. So
yeah, it's applicable in every field of medicine, right?
Yes. Yep. Absolutely. We have genetic counselors in cardiovascular genetics, ophthalmology genetics, adult genetics, and prenatal genetics as well, and pediatrics. So it's from cradle to grave. Genetics, is part of who we are, and we are very blessed to have about 35 genetic counselors here at the University of Michigan. So it's a great group, and you're constantly learning something. It's never a dull day, that's for sure.
That's awesome. Well, thank you so much, Kara. I really appreciate it.
Heather, I've had a great time. It's always so great to talk to you, and thanks for making this so easy.